My name is Kim. I work on the lecture committee at the Princeton Adult School, and as you know, this is the final lecture of the series. Thank you so much for attending. I think that it's appropriate, after looking at all the healthcare and medicine from so many different perspectives, that we end with the question, how do we pay for healthcare? Catherine Hempstead, who is she was the director of coverage at Robert Wood Johnson Foundation, but now she's the senior advisor for healthcare. Since 2013, she's directed the Robert Wood Johnson Foundation's work on health insurance coverage. In addition, she works on issues related to healthcare price transparency and value. She joined the foundation in 2011 as a senior program officer in the Research Evaluation Learning Unit. Previously, she's worked for the New Jersey Department of Health and Senior Services and for the Office of the Attorney General, New Jersey Department of Law and Public Safety. And she was in D.C. this afternoon giving a lunch lecture and rushed home so that she could give the this evening's lecture to us. Please join me in welcoming Catherine.
Hello, everybody. I'm really glad to be here on your last class. I'll try to keep it light and fun and not too long. And whenever you want to make a comment, ask a question, please feel free. I'm not going to be able to necessarily answer every question you might have about how we pay for healthcare, especially how much should we pay for healthcare, but I think we can sort of go through some of the issues that make it a very vexing kind of a question. And so just a little overview of some of the things we're going to talk about first is what's unique about healthcare? Why is it an industry that's unlike other industries? Some basic facts about health insurance, how it works. I'm sure you know a lot about that, but just sort of laying a little groundwork there. Who pays for healthcare in this country? What are we paying for? How should we feel about affordability? And finally, why is the U.S. different than other developed countries? And what are some of the arguments people make about the system that we have and how maybe it should be different? So let's start out talking about why healthcare is special. Healthcare is an input into the creation of health, and it's obviously not the only input. Lots of other things determine whether or not we're healthy. Our own behaviors, where we live, what we eat, a variety of things. But healthcare is an important input into health, and health is something that is sort of a foundational good, and many people think of it as sort of a good with intrinsic value. It's sort of necessary to have health to enjoy other things in life. Some people call health a special good, and think of it as the foundation of all other goods in this life, for example. So health is something that has kind of a special place compared to lots of other things that we think of, and that makes the way we think about paying for health care different than lots of other examples of things that we pay for, even collectively as a society. So, I think one way to think about it is that we have a higher preference for equity in healthcare than we might in lots of other areas, because there is a feeling that health is intrinsic to human happiness. It's a special good. Some people say health is a human right. Healthcare is a human right. So when we think about how we pay for healthcare, we're affected by the intrinsic value that we place on health. And using a quote from a very famous local resident and health economist, Uwe Reinhardt, says, in the ideal world envisaged by left-of-center Americans, the individual's healthcare experience would be independent of that individual's socioeconomic class. So we have a preference for equity in health. Now, that doesn't mean everybody has the exact same preference in mind and that we all agree on what kind of equity we should create with respect to healthcare. But there is this way in which health is different, and we do want people to be able to consume at least some healthcare, whether or not they're able to pay for it personally themselves or not. So healthcare is a special good. Because it's a special good, and we have this demand for equity, another thing I forgot to mention is there also sort of a spillover issue with health. Other people's health, even if we didn't necessarily care about them being healthy from an equity standpoint, other people's health can affect us. We can get diseases from other people. People can steal things from us, if they're addicted to drugs, or if they're, having other kinds of problems, people can impact us negatively by having bad health. So it's also an issue where there's spillovers, which is another argument for a large public role in healthcare. So because of all these things, we have a large public role in healthcare, and that makes healthcare a very complicated industry. First of all, there are a lot of political issues, because lots of times when we're talking about what to do about healthcare, what we're really talking about is redistributing income to a certain extent. And that becomes very heated sometimes, and there are people that have very different views about how much we should redistribute income. It also means healthcare is highly regulated, because a lot of the money being spent in healthcare is being spent by the government. So it's a very highly regulated industry, and it's also, again, vulnerable to fraud because there is a large public payer, and so that's constant back and forth in healthcare. So these are all things that are kind of tricky about the healthcare industry compared to some other industries. Also, just sort of thinking about health, health is unpredictable. You don't know what kind of health needs you might have. You could find yourself all of a sudden realizing you have a condition that's very expensive to treat, or an arrow could shoot you in the head, or who knows what happens. There's a unpredictability and a potential for very high costs in healthcare, which is why there's also this need to finance healthcare, and that means that there's this very important role for insurance, which is another kind of tricky thing. Another thing about healthcare is that it is an industry that is characterized by asymmetrical information. So when you go to the barber to get a haircut, the barber knows more about how to cut hair than you do, and you can't cut your own hair, you need the barber. And the barber might tell you that you need a haircut more often than you think you do, but at the end of the day, you know whether you liked your haircut, you know when you need a haircut, and you can kind of play your role as a consumer. In healthcare, people are dealing with experts, and experts are telling them, you should do this, you should do that, you need to do this for 10 weeks, et cetera, et cetera. And there's an asymmetry in expertise and information, which often results in people doing things that aren't necessarily high value, but not knowing it. So that's another tricky thing about healthcare. And then it's also just the giant, giant, giant industry that is right now, growing ever more quickly. So it's for all these reasons, it's a very special, complicated industry, and a lot of people are really drawn to it and think it's fascinating, but it's also a huge component of our private and public expenditure, which is what we're here to talk about today. So that's the case for saying healthcare is a special industry, and I think it's pretty easy to see some of the reasons that it is. So let's talk about health insurance now for a couple of minutes, because as I said, because of this unpredictability in what kind of healthcare you might need and how much healthcare can cost, there's this need to finance it. People can't just, take out a credit card necessarily and pay for anything that might happen to them from a health perspective, so that's why we have insurance. The largest, just showing you the sort of big buckets of insurance groups, and this is probably something that you know kind of instinctively, but you might not have really thought about it that much, but the largest group of insured people is people that have employer-sponsored insurance, and that's something that's unique about this country. A lot of people have employer-sponsored insurance compared to other European countries, and that's really a kind of a funny artifact from after World War II, when there was concern that wages were rising too quickly and employers were trying to recruit employees, and it was a tight labor market, and the government was concerned about too much spiraling wage inflation and curbed that, and instead employers started inducing labor by offering them these benefits. And it's just something that's that's really stuck around and become a very important part of our fabric, and a little bit later we'll talk about the sort of the tax incentive aspect of that. But that's the biggest single component of insured people is people that have employer-sponsored insurance. And some people have, I won't get into all the details, but there's a small group market, there's a large group market, and then there's a lot of people who the employers sort of self-insure, meaning that they pay all the claims themselves and they use an insurer kind of as an administrator, but the insurer isn't really taking risks. So there's a little bit of variation in that. But that's obviously a huge component of insurance. And then we have Medicaid, which is the second largest group. And Medicaid is something that is for a variety of different populations. It's for low-income people. It's for people who have certain kinds of disabilities, like people with developmental disabilities. And then it's also used for low-income elderly populations who sort of spend down and then don't have money to pay for sort of non-medical parts of their care that they need, like long-term care and housing, stuff like that. And that is a program that is currently funded by the federal and state government. And in fact, there are 50 different Medicaid programs, one in every state. And in a little while, we'll talk about some of the, I think when Heather was here, she talked about the ACA and the expansion of Medicaid and some of that stuff. But, we can talk about that again for a minute. So, Medicaid is very much in the news lately. And then, of course, there's Medicare, which is primarily for the population 65 plus, and there's traditional Medicare, and there's Medicare Advantage, and then there is some Medicare that people receive that are under 65, more often for people with acquired disabilities, but that's a component too. And then finally, the smallest part of the insured population is what we sometimes call the individual market, sometimes we call the non-group market, same thing, but those are people who go out and buy themselves insurance. So when we think about the Affordable Care Act and healthcare.gov, that's an online marketplace, that is the non-group market. People can go and buy themselves an insurance policy, and depending on their income, they can get a tax credit. That's sort of a new thing, and in a few minutes we'll talk about how the non-group market's changed. But those are the four big buckets, but you can see that the non-group market is by far the smallest part. Yes?
Where do you put active duty military and their dependents in the Veterans Administration?
There is a small insurance program for sub-military. There's a little other category I didn't really talk about. The Veterans Administration isn't really insurance, it's a place that you can get care, that some veterans can get care. But yeah, there are a few little other things. There's also the Indian Health Service, a couple little categories I didn't mention. But these are sort of the big buckets. So all insurance products on some level are kind of the same, right? There's some specification of covered benefits that is standardized by the public sector, pretty much without exception, by and large. Anything that's ACA compliant. And then there's this combination of premiums that people pay every month, and then there's some kind of cost sharing. And I'm sure all of you have insurance, or I would bet most of you have insurance, certainly have had insurance, and you know that there are many, many different ways to share the cost with your insurer. And there's also a lot of variation in what we call actuarial value, and this could quickly become very boring, so I don't want to get too technical about it. But actuarial value is basically how much of your premium, how much of your costs are covered by your premium, and how much do you have to pay out of pocket. So I don't know if you've been hearing people talk a lot about high deductible plans, or this trend in high deductible plans that a lot of people complain about, some other people don't mind so much, but it's basically a movement towards a lower actuarial value, a movement towards insurance plans where your premium doesn't cover as much of the total cost and people need to pay more out of pocket. Now, if the total cost of the coverage is kind of staying the same, for somebody who's working, what that would really mean is maybe they would have higher wages, but then they'd have to open up their wallet more to actually pay for care. So it's kind of it's a trend that's been going on in employer-sponsored insurance, and it's also something that we see in the new non-group market, where I don't know if you've heard people talk about these different metal levels of gold, silver, bronze plans. Does that sound familiar to anybody? So those are different actuarial values. So the gold plan, it isn't really better in any way in particular, that you're paying more of your total cost. Your premiums are going to be higher, but then things will be cheaper. Your co-pays will be less, your deductible will be smaller, etc. And bronze is sort of at the other end of the spectrum, where your premiums are going to be low, but you will be more likely to have to pay for things. So that's an insurance component that is very relevant to affordability and what people are paying. And then the final issue I just want to mention really fast is plan type, which basically means what kind of access to healthcare providers do you get with your plan. So You know, a lot of people have probably fee-for-service Medicare, which means you can go to many, many, many different providers. Almost every provider accepts Medicare. And you don't have a network really to think about. If you're in Medicare Advantage, then that's more what we think of as sort of a closed network kind of plan where you have a network. And those same kinds of distinctions go on in all kinds of insurance products. And so I don't know if any of you have heard about people talking about narrow network plans. Does that sound familiar, or trends toward? So it's something that's happening lately with insurance is insurance companies are trying to make the products cheaper. So they're moving toward plans where they contract with a small number of providers and get those providers to accept lower prices in exchange for more volume, and then they can offer the plan to the customer for less money, but then the customer is constrained to, you know, a small group of providers. And for some people that's fine, for some people they don't like it, but it's definitely something that people are talking about. So that's sort of a, you know, a big picture look at different kinds of, you know, insurance characteristics. So let's talk about the ACA for a minute and what the ACA did to insurance. And primarily what I'm going to talk about is the individual market, but it has some applications to employer-sponsored insurance too. So New Jersey is a special place, you know, in terms of the individual market, because New Jersey really had a whole lot of the reforms that the ACA put into place before the ACA, because it's got a very actively regulated insurance market. Did any of you know that? No, because hardly anyone is on the individual market. Has anyone here ever bought a policy in the individual market? Oh, okay, there's a few people. That's pre-ACA or post-ACA? Pre and post. Okay, okay. Well, so were you in New Jersey or somewhere else? Here, okay. Well, in New Jersey, they have something called guaranteed issue, which now they have everywhere. That's one of the main things that the ACA put into place. Guaranteed issue. What does guaranteed issue mean?
Guaranteed insurance.
You're guaranteed to be issued a plan, right? Even if you have a health problem, a pre-existing condition, you know, just like in an employer-sponsored plan, right? You have guaranteed issue, or Medicare, guaranteed issue, right? Individual market now too, guaranteed issue. In most states, except for, you know, New Jersey, New York, Massachusetts, a small handful of states, in most states before 2014, the individual market was kind of like a frontier. It was sort of like the wild, wild west. Most states had something called medical underwriting, which basically meant if you had a health problem, you may be, just with life insurance, you know, it would affect how they would rate you. And some people, they would just say, I'm not going to write you a policy. So the individual market in most of the country was not really standardized, and it wasn't organized in a way that people could count on getting insurance. So one of the things that the ACA did is they said, okay, from now on, all over, we're going to create this national regulation that everyone has to do guaranteed issue. And then the other part was community rating, which goes with guaranteed issue. And what does that mean?
Can you explain the average of your area?
Yeah, your area and a couple things. They can only use a couple things: your age and whether or not you smoke. They can't try to affect your rates based on anything else about you, like, you know, whether you have a medical condition or your race or your gender, anything, just your age and whether or not you smoke. So this was a big deal. Living in New Jersey, it didn't seem like, you know, how else would it be, you might think. But in most of the country, this was a huge change. Did you raise your hand?
Yes, what is ACA?
The Affordable Care Act. I'm sorry, Obamacare. When we talk about Obamacare, a lot of people are just thinking about those tax credits and those plans, but it really was a big list of regulations, and that was one of the most important ones. So it created this market in the country, in every state of the country, that didn't really exist before. Other things about the Affordable Care Act is it sort of defined what the benefits would be. It created these standards, like, okay, if you're going to offer a policy, it's got to cover these 10 essential health benefits, which do vary a little bit state to state, but they're kind of pegged to the most common policy in the state. They also created these standardized, the metals, you know, bronze, silver, gold, these actuarial values. And then another really important part about the Affordable Care Act was they also added an individual mandate, which basically said if you don't have insurance, you have to pay a fine. If you can't show that you have insurance, you have to pay a fine. And, you know, people sometimes can not pay the fine because they have a hardship exemption, but in general, people that don't have insurance, you know, have to pay a fine. And there's also a mandate on employers. If employers aren't offering insurance to, you know, to their workers, they have to pay a fine. The other thing that the Affordable Care Act did in this individual market is it started to offer tax credits to people if their income was below a certain level, so that people would go on to, in New Jersey, we go to healthcare.gov, you enter some information about your income, and then you see if you're eligible for a tax credit, and that tax credit makes your health insurance cheaper. The other thing about the Affordable Care Act that was part of it was that the idea was that every state would expand Medicaid eligibility up the income ladder so that more people could get covered. And as I'm sure a lot of you know how that's playing out around the country. A lot of states have, and a lot of states haven't. And a lot of states are trying to find a way to do it that works for them, which would be maybe expanding Medicaid but requiring people to pay a little bit of money or put it into a savings account or make people take job training. Has anyone followed any of these issues about Medicaid expansion in, say, states like Tennessee, or, you know, kind of grappling with it and trying to get the federal government to approve of their proposal for how to do it? And some things the federal government will agree with, and then some things they'll say, nope, no work requirements, you know, we draw the line here and here. So some states have expanded, some states haven't. New Jersey's expanded, but about, you know, 20 states have not. The other thing that I just want to mention right now about the ACA that was really important, but it got sort of put on the blocks for a while, is something called the Cadillac tax. Has anybody heard of the Cadillac tax? So what's the Cadillac tax?
40% high value, high cost plans.
Yeah, exactly. And what's the idea of it? What's the reason to do it?
Would create revenue and the cap excesses in rich and generous plans.
Right, exactly. Because, you know, one of the things about the employers offering insurance is they get this incredible tax incentive for paying for people's health care. And one of the things that it does is it makes employers, incentivizes employers to sort of substitute health benefits for wages because they get this tax incentive. So people end up with these extremely generous plans, which then make them not be careful consumers of healthcare because, you know, this has changed a lot, but in, you know, kind of in not very long ago, a lot of people might have had a health insurance plan where they hardly paid any premiums. Maybe they only had like a $5 copay for anything, and they just weren't very, you know, they didn't really think that much about whether they got something or not because nothing cost them any money. But the reality is all of that was in place of wages, really, because I think people tend to think their employer is buying them health insurance, but it's really part of people's compensation. So the idea behind the Cadillac tax, besides raising revenue, was to sort of say to employers, give people more wages and less health insurance. That would really be better, because then people would stop kind of wasting money on health care, and they would, you know, they would have more money in their own wallets, and they would decide what to do with it. But right now, the Cadillac tax has been pushed back because a lot of people are very, very frightened by it and very upset by it, because a lot of companies were going to push up against it, and so that was delayed. So that's kind of a whirlwind tour of what, you know, what's going on with the Affordable Care Act. You know, there's other things too, but all these things are designed to expand coverage. So basically, you know, to have financial access to health care, you need health insurance in this country. So the ACA had a lot of ideas to try to make more people have health insurance, whether it's on this individual market, expanding Medicaid, giving employers mandates, etc. And so here's, you know, it actually seemed like it had a decent effect. And we have seen really a historic decline in uninsurance since this passed. And a lot of it was people signing up for Medicaid. Some of it was people going to the new insurance markets. Some of it was people taking an offer from an employer that they hadn't taken before. So it was a lot of things. But, you know, they estimate, about 18 million people all in all gained health insurance coverage because of the Affordable Care Act. Another thing I didn't mention is before they opened the exchanges and all that stuff, another part of the Affordable Care Act was to allow adult children to be covered on their parents' plans up to the age of 26, which again, New Jersey had already done. But it was a big deal in other places, and that added a couple million people too. So that's all the coverage expansion stuff with the ACA. And now this is a very busy graph, right? But this kind of shows you, you don't have to worry about all the details of that. This sort of shows you where everybody is. And the red part are people who are still uninsured. So those are the remaining uninsured. It's like 29 million people. And of that insured population, like a quarter of them are not eligible for anything. So who would they be? Who are people that are not eligible for anything? Undocumented immigrants, right? And then there's another group. No, not smokers. People who are in what people call the coverage gap. Have you ever heard that phrase? Those are people who live in states that didn't expand Medicaid, but their income is so low that they can't go to the market and get a tax subsidy to get a marketplace plan. They're actually not allowed because those subsidies are only for people with incomes above 138% of poverty, because that's the way the law was written. So people with the income below 138% of poverty living in a state like Oklahoma, Florida, Texas, these are people that are in the quote-unquote coverage gap, and there's about 3 million people like that, and there's, something like 3 million undocumented, and then the rest of the uninsured people are eligible for something, and they're just not taking it. So that's actually a lot of progress, really, compared to where we were a couple of years ago, but that's still a reasonable number of uninsured people. So what do the uninsured people do? How do they access care? Well, these are people that use the quote-unquote safety net. So those are federally qualified health centers. You may have heard of those. Those are kind of clinics that let people pay for health care with a sliding scale. They ask you if you have any money, and you either pay nothing or pay, $2. When people go to the hospital, they end up being charity care patients. You've probably heard of charity care. That's always a big issue in New Jersey, how much charity care money the hospitals will get to pay them back for uncompensated care. And, people also would patronize retail clinics, which, lots of people patronize retail clinics, and they accept insurance, but they'll also, have a reasonable price for a visit. So since the Affordable Care Act passed, and so many people did gain coverage, like in New Jersey, we expanded Medicaid, and actually charity care spending in New Jersey's gone down because there's less uncompensated care because there's fewer uninsured people. So every year the state gives out a lot of money to the hospitals, and this year they gave out less. And last year they gave out less because there's not as much. Of course the hospitals still act like they maybe need it all anyway, but it's hard to let go of that money. But the truth is there's not as much uncompensated care as there was. So that's sort of the landscape there. So now let's talk a little bit about how do we pay for all that? Like, how does that all get paid for? I just explained all these different ways that we have financial access to healthcare. So how do we pay for it? Well, it costs a lot of money, okay? It's $2.8 trillion in 2013. I think that's the last estimate I have. Total spending on healthcare. That's everybody. That's you and me and government, everybody. It's about 1/6 of our GDP. So that's like, one of every $6 that gets spent in this country is spent on healthcare. And it's close to a 50-50 split between public money and private money.
Can I ask,
Sure.
if you took out the end of life radical, like I want to stay alive no matter what feature, what would that 2.8 trillion go down to?
Not as much as you might think. I mean, that is a very
We had other
expensive.
presenters discuss and
Yeah.
say that that's a huge part of that 2.8 trillion. But
I can't say exactly how much it is. I mean, it is very expensive end-of-life care, and a lot of times it's low value to everybody, so it's a huge place where people are looking. But I couldn't say, it's not like the whole story, for sure. But here's sort of a breakdown. I don't know how, this is sort of a stack, and the bottom blue, I hope you can see the labeling, okay. The one at the bottom is Medicare, so that's 21% of everything we spend. And that's the public part net of whatever individuals pay as premiums. So that's sort of the net public outlay on Medicare. Then Medicaid, which you can see is not that far apart, from Medicare. And that's federal and state spending on Medicaid. And then there's the little other band is things like charity care, the safety net, the CDC, public health, things that aren't necessarily providing healthcare services to individuals, not all of that, but it's other public spending. Then we have what private health insurance companies pay, and that's basically ESI and, money that people pay on the non-group market, and then out-of-pocket expenditures, and then just a small other category. So it's, a little bit more than half private, but it's a really, really large amount. And just a few other numbers, just looking at the population under 65, the CBO just put out a report that estimates that this year the federal government will spend $660 billion on that population. And I just want you to notice that the ESI tax preference is a big part of that. It's $268 billion, it's 41%. And then there's Medicaid, and then there's a small amount on Medicare for people under 65, and then there's the ACA health insurance reforms, which, they cost something, but they're a pretty small part of the overall picture compared to some of the other expenditures. And then there's a little offset that comes from taxes and penalties. So those are some big numbers. So we know that we spend a lot of money on healthcare, and then we are interested also in thinking, well, what's happening to that? Is that amount growing every year? And the answer is, oh yeah, yes it is. But it doesn't always grow at the same rate. So actually, this looks like a nice gentle rolling hill, kind of, and it shows year-over-year growth in national health expenditures, which means everything, the total amount of money our economy, our society spends on health, for the last couple of years. And you can see that after the Affordable Care Act passed, we saw this growth rate going up every month. And, why do you think that was? More people got coverage, right? And when people get coverage, people that don't have health insurance use health care, but people that do use more, right? So people got coverage, and there's a little rule of thumb that someone with insurance will use 40% more health care than someone without insurance. It's very rough. But when you give a lot of people insurance, they'll use more health care. So we do see this increase. A lot of people would say, that's sort of okay. That's better than just paying more and more for the same thing. At least we're paying more and more people are getting health care. But now that's sort of plateaued. I don't know if anyone really follows, the open enrollment season, but many people might know that in the last open enrollment period, not that many new people signed up. A lot of people feel like the coverage expansion's kind of plateaued now. We're not going to see any more giant jumps in coverage. Somehow those 29 million people, some of them are going to trickle in over time. Some of them won't. But that increase is slowing down, and as that happens, that's sort of the top of the hill there. It's like the beginning of 2015, we started to see a decline, not in healthcare spending, a decline in the growth rate of healthcare spending. So it's still growing, it's just not growing as fast. And so now we get to the February 2016, we see again a tiny little uptick, but we have seen recently this sort of expansion that a lot of people relate to coverage expansion, and now we have seen that subside. And so now, that driver of healthcare spending growth is over. So now we have to kind of think about what other drivers there are that we might be concerned about. And this just it shows the trend in healthcare spending and GDP. So let's kind of break it down a little bit now and think about, when we talk about spending money on healthcare, what are we spending money on? What are the big categories there? So here I have a little pie chart for you, which is sort of the big ticket items. And again, this is what our whole economy spends on healthcare, the whole thing. So what's the single biggest category? Hospitals, right? That's a third. So like a third of every dollar that our country spends on healthcare is spent on hospitals. And then the second biggest chunk is physician and clinics. And then the green one is dental, and prescription drugs is about 10%. It gets a lot of attention. And then there are other kind of, you know, different, there's home health, there's nursing homes, there's different other kind of smaller categories. And even, you know, public health spending and the administrative fees of insurance company. I mean, everything's in there. But the big ticket items are hospitals, doctors' offices, prescription drugs. Those are sort of the main categories of healthcare spending. And that's why a lot of the things that we talk about when we talk about trying to control spending growth in health has to do especially with doctors and hospitals and how much they get paid and what we're paying them to do. And I'll talk about some of those things in a minute. And this just shows a little bit of the growth in some of these categories over the last 12 months. And I know a lot of people have been thinking about and talking about growth in prescription drug spending, which has been high. And it's still over the overall trend, but it's not growing as rapidly as it was last year. But there's always a lot of potential there for growth. So let's talk about provider prices for a minute, if that's okay. Because this, you know, whether we're talking about hospitals, whether we're talking about doctors' offices, this is a really big component of healthcare spending. It makes sense, right? I mean, we consume healthcare, we go to the doctor, we go to the hospital, they get paid. I mean, it's not a surprise. But there's a lot of discussion about what we can do to try to address this in a different way. So how many people have heard people talk about fee-for-service versus alternative payment methods? Is that familiar to anybody? Yeah, some yeses and some no's, right? So fee-for-service is what it sounds like, right? You get a service and you pay a fee. When you go get your hair cut and go to the barber, that's fee-for-service, right? You get your hair cut, you pay your barber. Doesn't seem like there's anything wrong with that, right? But why would somebody complain about fee-for-service or think it's a bad way to pay doctors?
It doesn't look at outcomes. It just more is better, so they'll prescribe more, they'll do more.
Okay, that's exactly right. And again, that kind of goes back to the information asymmetry, right? If your barber started to say, hey, you should get your haircut every day, you would say, you're crazy. No, because you know how often you want to get your haircut. But if the doctor tells you something, you might not really know. So fee-for-service, the good thing about it is it's simple, right? It's easy to measure, it's kind of easy to understand. But what people think is not so good about it is that it can give providers the wrong incentive, right? To get paid for volume, to get paid for services, not necessarily getting paid for outcomes. So one of the ways people are trying to rethink this is to have what gets kind of clumped into alternative payment methods. But I don't know if you've ever heard of accountable care organizations, ACO. Is that familiar to anybody? Or value-based, yes, value. So what do you think that is?
It's an attempt to set up a structure that's not fee-for-service.
Not fee-for-service. No, you're right. And actually, it's kind of, there's sort of a million different versions of it. So there's no one thing, but it's paying providers for something else besides volume. It's maybe paying them for the health of a population, for some kind of outcome. Or it's paying them to keep costs below something. It's paying them to keep, well, here's a good example. The Affordable Care Act, one of the things that they included was something that would give hospitals a penalty if too many people were readmitted. Has anybody heard of that? So that's another example of something that tries to create a different incentive structure for providers, because if hospitals might feel like, hey, I wouldn't mind readmitting this patient because it's, you know, it'll be a pretty nice payment. I'm not going to try that hard to avoid it because I have a lot of beds to fill, and you know, Medicare pays very nicely for inpatient hospitalization, so I'm not going to, you know, go to too much trouble to prevent this from happening. So the idea is to create an incentive, this is sort of an alternative payment method, instead of just paying the hospital for doing services, to say, I'm gonna give you an incentive not to let this happen too much, because if you do, I'm going to, we're gonna fine you. You know, whenever you do things like that, it sounds great, right? But it's very complicated to do things like this. And then people will say, well, that's not fair, my patients are sicker, it's too hard to keep them out of the hospital, it's not my fault, it's the skilled nursing center's fault. And I mean, it's very, very complicated, but people are experimenting with all kinds of things like that now to see if there's other ways to pay providers so that they're not incentivized to do the wrong thing. Have you ever heard people talk about high deductible health plans or skin in the game? Giving people more skin in the game. So what do you think that's about?
Gives the patient less incentive to seek follow-up care or more care, because every time they seek care, they're paying a higher deductible than they otherwise would expect to pay.
That's exactly right. That's exactly right.
It's a really nice alternative if you happen to be a healthy person.
Well, that's a good point too. Right. I mean, it is another alternative payment method, actually making the provider get more of their money from the patient. And in the kind of the old days where people had very, very, very high actuarial value plans where like everything cost, you know, $3 or something like that, you didn't have any skin in the game, and you didn't care because it didn't cost you any money, so you would basically just go along with anything. So the idea is let's activate the patient to be a better consumer. But you know, it's not as good if you actually find you really are sick and need to spend a lot of money. And it also brings back that information asymmetry again, where people may feel like, I don't know whether I should get this care or not. Yes?
How can I be a good consumer if I don't have the information? In fact, it's very difficult to get the information from hospitals about how much a colonoscopy is going to cost here versus there, and how much the anesthesiologist is going to cost from here or from there. And if you're sick and you're taken to the hospital with a heart attack, you don't sit there, you know, in the ambulance calculating and saying, oh, no, take me to this hospital and not that one. I mean, it's a very different thing than going out and buying a new pair of shoes or a suit or something like that.
I mean, you're right, and this comes up all the time. I mean, people talk about that very thing and say, you know, there's a relatively small share of healthcare decision-making that's discretionary, and you can't solve all these problems on the backs of consumers. And, you know, it's not reasonable. You know, then other people say, well, let's really concentrate on elective surgery, shoppable moments like maternity care, things like that. But a lot of people push back and say you have to provide people with information so they actually can make these choices. And I think the growth of more and more information that makes consumers feel a little bit more confident about, there still is an information asymmetry between patients and doctors for sure, but it's less than it was. It wasn't that long ago where people would act like you should never look for medical information on the internet. Does anyone remember that? You know, don't look at Dr. Google, or, you know, that would be a silly thing to do. But now most people do know that they can get useful information on the internet, and lots of people do. And so I think some of the information problems are getting lessened. But yeah, I mean, that's a very, very valid point, and a lot of people talk about that all the time and say you're just sort of dumping it on consumers, and they don't have the tools they need to actually make the decisions. Yeah, your hand up.
What about capitation for a particular disease? Any kind of instance, if you have a heart attack, for example, it should be capitation for that episode in your healthcare.
Well, there is, yeah.
Payment methods.
There is there's something called bundled payments. I don't know if you've heard about that, but there are certain things like total knee replacements or hip replacements and a couple other things where CMS is really starting this with Medicare, but usually Medicare kind of drives the bus. Like things that start in Medicare will trickle out to other payment systems, but they're saying to hospitals, you know, you guys have to, you and the post-acute care people, the whole team of people involved in this have to deliver this service for, you know, for some price, whatever it is. And then they say to the patient, basically, I'll pay for this procedure if you choose one of the providers that's going to offer it under what they call a reference price. And if you choose someone that costs more, you're paying the difference. So there are a couple of sort of straightforward procedures where there's a real sense they're common and there's a real sense of what they should cost, where they're trying to get providers to work together and give a joint price. And that's something that's really new, because I don't know if any of you have ever been in the hospital or been in the hospital and then been in post-acute care. You know, you get all these different bills and it's like nobody's really working together and everyone's just billing for their services. So a lot of what's going on with some of these attempts to get providers to get paid in a different ways, to get them to work together and give you sort of a price for a bundle of services. And, you know, just getting back to the hospital prices in particular, do any of you remember all of the kind of outcry that came out about this book called Bitter Pill? Does anybody remember that? It was a book and an article by this journalist. Yeah, you remember. What was Bitter Pill about?
The extreme difficulty of understanding financing of healthcare, and the Time magazine article.
That's right, yeah, and hospital prices in particular, right? And really went into a lot of detail about how hospital prices seem to just vary for ridiculous reasons that have nothing to do with the cost of delivering the care or what the quality is. And there's this crazy list of prices called the Charge Master that hospitals still use, and they base some of their negotiations on it. And that book did a lot to kind of kick off some of what people call sort of the transparency agenda, which is trying to do more to make hospitals say what their costs are in a clear, realistic, understandable way. Another thing that we try to do sometimes to get providers to charge less is we think about creating, I mentioned it already, that these narrower networks where basically payers will negotiate with providers and say, if I can give you a lot of business, will you give me a better price? How many of you have followed anything about the Omnia issue in New Jersey? So what's that about?
Horizon contracted with 7 major networks, 22 hospitals, Robert Wood Johnson included, to provide incentives for them and shared savings with 15 to 20% reduction. The tier 1 hospitals would get better benefits. There were more than just those 22 hospitals. There's 34 more in tier 1 with the better benefits. But that also meant that there were about 20 hospitals in tier 2 that have been long-time partners with Horizon that are now relegated to getting a lesser benefit. And then the third part of Omnia is that there's no out-of-network benefit. So if you don't go to one of those tier 1 or tier 2 providers or network providers, there's no benefit at all. So there's been a big outcry about whether that's been fair to the hospitals.
Right. It's a really, really interesting issue because one of the funny things about hospitals in this country that is really strange is all different payers pay them different amounts for the same service. Did you all know that? You probably did know that. Like Medicare pays a price to a hospital, which hospitals act like sort of just meets their needs, like they can live on what Medicare pays them. Then Medicaid pays them a price that they say they lose money on, right? But it's not as bad as charity care. They lose money on Medicaid. How do they make up the difference, do you think, with commercial insurance? So they basically, and this, have you ever heard anyone talk about payer mix? So it's basically the mix of payers that a hospital has, rich payers and poor payers, good payers and bad payers, so they want to make up that difference with commercial insurance. So when Horizon made the Omnia network, the real complaining came from the tier 2 hospitals, because the tier 2 hospitals said, well, now we're going to lose all these good payers, and we're only going to have, some of them said we're safety net hospitals, which means they treat a lot of Medicaid and uninsured people. We don't have a lot of good payers, and we're losing these good payers, and we might go out of business, et cetera. So it's a very interesting issue because in a certain way they're asking Horizon customers to kind of subsidize them by overpaying them so that they can stay afloat. It ends up being a very, very strange issue and has a lot to say about the very bizarre way that we pay providers and price healthcare in this country. Because if you really think about it, there's no particular reason that Verizon customers should feel obliged to subsidize tier 2 hospitals, but that ends up being the way this issue is raised, yes?
Is this system working, or are patient consumers rejecting it?
I've heard, and we're just going to get the first enrollment data very, very soon, but I've heard a lot of people have enrolled in it. Consumers are saving money. They're pretty happy, I think, although remains to be seen. Horizon had to get their network approved by the Division of Banking and Insurance to show that they had adequate coverage all over the state, and they did get that approval. And I've heard a lot of people have enrolled. I want to learn more, but it's really not consumers that are complaining. It's really the tier 2 hospitals.
But is it, when you say adequate coverage, is it equitable coverage? I mean, do you have places like Camden and Newark and Red Bank that are getting shafted because?
Well, that's what they had to demonstrate to the Division of Banking and Insurance, that they had what people call network adequacy, to say, no matter where you live, you have enough providers, based on where you are close enough. I mean, one thing about New Jersey compared to a lot of other places, we have a lot of hospitals. So you can definitely leave some hospitals out and still have a lot of hospitals compared to other states. But I also think that puts a lot of hospitals in a very tenuous financial position, so that little things like this are very upsetting. It's a very, very interesting issue, and I'll be curious to see what the enrollment looks like and how the customers react. But I mean, a lot of people feel like their health care is unaffordable and they're looking for a cheaper option. So, yes?
Just note on that, they have 230,000 enrolled as of January. That represents about 10% or 12% of Horizon's stock commercial business. So they didn't think that, they get 50% or 60 or 70%, but it'll affect you all. I mean, this is affecting the hospital networks within this state profoundly. And the question is that right? I mean, is it right to reward certain hospitals? And they're basing it on outcomes of care. So that's, I think, where the controversy comes in. But to your point, there are counties that don't have those hospitals. There's 74 acute care facilities in New Jersey. 22 are favored tier 1 hospitals. Another about 30 are tier 1. So you have about 50 of those, but there's about 24 that aren't. And that's after a loss of about 12 hospitals that we had back in the 90s and into the 2000s. So is it accessible? Less so. That's the idea of the tier. So I think this is, and hopefully I'm not biased in any way in presenting this information, but it is affecting the hospitals that you're going to and the quality of care in the state, maybe for good or maybe for bad, depending on your vantage point.
And a lot of other states have actually just gone to a very narrow network, and that's something that didn't happen here. So people still can use the tier 2 hospitals, but they have to pay a higher copay. So it's a really interesting issue, because on the one hand, Verizon will say, hey, I'm a private business. I'm not for profit, but I can choose the suppliers that I want to work with. I want to work with this handful of hospitals and not that one, and that's really my business. If my customers don't like it, then I'll lose business, but I don't need to account for my choices. But then the tier 2 hospitals say, this decision should be completely transparent, and Horizon should list their reasons, their standards, and anyone who meets the standards should be allowed to be a tier 1 hospital. But what do you think would happen if you did that actually?
Some hospitals are closed.
Well, I would think what would happen is the people they asked first would then say, well, I only wanted to take this price if you were going to cut out my competitors, because now I'm not going to get the volume, I'm just going to get the low price, so I'm out. I mean, I don't know for sure, but I wouldn't be surprised if that would happen. So, did you have your hand up? Go ahead.
Well, I did. You mentioned about different hospitals charging different amounts for the same procedure. What about the case where a single hospital looks for different amounts of money depending upon who's paying? In other words, I have good health insurance, I had a procedure in a hospital, and the bill came with a huge amount. But then because of my insurance, the hospital was satisfied with what their deal was with my insurance coverage. Yet my feeling was that if I were uninsured, that hospital would come to me for that entire amount, sue me for that amount, maybe drive a person into bankruptcy for that amount, when in fact, they were taking 25% or 30% of that amount from somebody who's insured. Why doesn't the uninsured, do hospitals like yours, like Robert Wood Johnson and others, go after uninsured people for the total amount on the bill? Or do they look just for what the insurance company would have paid?
I have nothing to do with Robert Wood
No,
Johnson
no,
Hospital.
no, no, no.
Just the foundation and the hospitals are separate, I just wanted to let you know.
Take Robert Wood Johnson out.
But yes, they will try to do that. New Jersey passed a law that said you can't try to charge an uninsured person more than 115% of Medicare or something like that. But a lot of states don't have laws like that. So yeah, yes they do, and you're absolutely right. Hospitals will accept different payments from different payers for exactly the same procedure, and they're trying to create this mix where they get as much commercial business as they can to balance out the Medicaid and the uninsured. But you know, I mean, and that's really what this Omnia thing has kind of blown up about, is like, you know, does the largest insurer feel like they have to sort of subsidize these tier 2 hospitals? And it's a really, really interesting issue. Sometimes you see the charge master when you see your hospital bill, and that's actually an amount really that nobody pays, but that's their kind of pretend, you know, they might try to charge like a prince from Saudi Arabia that, or someone that they, you know, a lot of New York City hospitals do, I think, bill charges to foreign nationals that have no limits on their money. But yeah, that is something that's really infuriating. Well, have any of you ever had an out-of-network bill? That's sort of the same thing in a non-hospital situation where you get billed some rate that's much higher than what the person would have taken if they're in your network, and it's, you know, it's exactly the same kind of situation. So there's a real lack of rationality in the way we pay providers. Another thing we try to do more and more to keep costs down is expand scope of practice and try to have everybody working sort of to the top of their skill level, so that you can see more and more nurse practitioners, physician's assistants. Have any of you ever seen nurse practitioners or physician's assistants? Right, I mean, that's something that didn't happen that much just 10 years ago. But we see a lot of expansion of scope of practice so that people that don't charge as much can do more, and you know, people that charge more can really do things that they need to do. Now I can see I'm almost using up all the time, so let me just hurry up, because oh my gosh, we're almost out of time. So another thing that we try to do is, and it's sort of related to some of the payment mechanisms we talked about, is try to find ways to get people to use less care. And I think having high deductible plans is one way. But there are also, have any of you ever heard of a program called Choosing Wisely? Is that familiar to anybody? No. It's a list, and I don't know how valuable it really is, but some medical specialties have come up with lists of what they consider to be frequently overused tests and procedures. They tend to always be things that other specialists perform. I'm not sure. But the idea is people should think about it and choose wisely. Since we're really running out of time and it's your last day in class, let me just get to, I wanted to show you some ways that the U.S. system is different than other countries. So I'm skipping through a couple of things, but what's unique about the U.S. health system compared to other developed countries? A lot of people make this complaint about us. We spend more, we get less. We spend a lot on health care, but our life expectancy is not as high as it should be. We don't have as much equity and access. We've made a lot of progress with the ACA, I think, but you know, we don't have universal coverage in this country. There are uninsured people that don't have financial access to health care. We pay a lot more for drugs than people in other countries. I'm sure you've heard about that. And doctors get paid a lot more than they do in other countries. And I just wanted to show you a couple of things really quickly, and then I know we're going to be out of time. So this is the U.S. compared to a lot of other European countries. Health spending as a percent of GDP. We're the black line on the top. So you can see that we're really, really different than a lot of other countries. We have the lowest life expectancy. Now that's not because our healthcare system stinks. I don't think anybody really thinks that. That's because we shoot each other, smoke, do a lot of stuff, you know, that we shouldn't do. We have a lot of guns, you know, but there is this argument that people will make that says basically, we spend more and we get less. So this is a plot where you kind of see the two red dots at the end are sort of what would be predicted based on how much we spend on healthcare, and then the lower dot is what we really get, which doesn't really mean that our healthcare system is bad. It means there's a lot of things that affect health that aren't healthcare, but we do spend a heck of a lot on healthcare. But I just wanted to show you this. We don't have more doctors than other countries. You might think that we do, but we really don't. This kind of shows doctors per population. We don't really visit doctors more than other countries. This is visits per thousand. That's not our problem. It's not utilization, it's price. So this shows physician costs, 2013 for bypass surgery. We're at the bottom, $75,000 compared to these other European countries. And appendectomy, $13,000 compared to other European countries. So the problem in the US is really the price that we pay providers. Doctors in this country make a lot more money than they make in other countries. And that's just something that's, always been, for a long time, been this way, but there are really a lot of activities now taking place to try to, think about ways to pay providers less. And that's sort of an ongoing battle. But this is why a lot of people say we should have a single payer system, right? And this is just kind of the last point I want to make. A lot of people feel really frustrated with our system, they say. We spend so much on healthcare, yet there's still people that have no insurance. And we have a low life expectancy, and this system's not working. Why don't we have a single payer system? Has anyone ever heard anyone say that, like Bernie Sanders or Medicare for all? So, what would a single payer system mean? Well, there could be a lot of different kinds of single payer systems, right? But it would basically be something where healthcare is funded through taxation. And we already see there's a huge public role in healthcare now, right? So it would just, it would be different. You wouldn't get health insurance from your employer. Somehow it would be provided by the government. And it'd be, taxes would go up, but your wages would probably go up, so you might spend about the same amount of money. Everybody would have access to the same system of care. But, you can imagine a lot of different ways that you could do it, but I mean, when you hear Bernie Sanders talk about it, it's super easy, right? It's to save millions of dollars, because you would eliminate the insurance companies. What do you? I'll just ask you as final things just to talk about before you're done. What kinds of problems would a single payer system solve? But what might be tricky about a single payer system?
Presumably everybody's covered.
Yep, that would solve the uninsurance problem.
I know in some countries, for example, Canada, Israel, etc., there is public single-payer system, but if you really want to see a really good doctor or you want to be seen faster, you go privately and pay for it.
Right.
And that would probably happen here as well.
It probably would, yeah. There would either be long waiting or some sort of, supplemental or alternative system.
Well, one of the things that we do is resolve the disparity between, geographic disparity between the kind of care you get in Mississippi versus you get in New Jersey.
It might, but I mean, you'd have to put a lot of resources into really rural places that not a lot of people live. And you could do that, but what might that do to costs?
So if the quality of care is the same and the access is the same, it will reduce the disparity.
It could reduce the disparity. It could increase spending, but it could reduce the disparity. What about when Bernie Sanders says, we'll save billions and billions of dollars because we'll cut out the insurance companies? Does anything strike you as, wait a minute about that?
Yeah, you got a lot of people working for the insurance companies.
What is the thing that the insurance companies do?
Paperwork.
Okay.
They're reluctant to pay a lot of money, so they monitor the efficiency of the institution that they're helping.
They're managing utilization, right? Do you ever have your insurance company give you a hard time about something, the medical expenditure that you?
All the time.
Right, it's annoying, right? What if nobody ever did that? What do you think would happen?
Medicare does it too. Medicare does it.
Medicare does it too, right? So,
If hospitals break even on Medicare prices, why do they, hospitals charge more than the insurance companies? They should charge the same price.
well, there's a few states that are experimenting with what they call global payment, like Maryland does that, to say every payer pays the hospital the same price. It's a very interesting idea. But I think the, cutting out the insurance company really would just mean that the public sector would have to manage utilization, because someone has to manage utilization, or else, you could easily spend the entire GDP on healthcare. Yes?
Medicare, as I understand it, has a much, much lower overhead than private insurance. But why is like this 3% to 17% or something like that overhead? Why is there that enormous difference?
Well, private insurance has actually gotten regulated a little bit now. They have these medical loss ratios that are designed to cut.
Right now, they have to return some money if they don't spend a certain percent.
Let's assume you're taking care of the managed part. What is the profit of our insurance world? Essentially, that's the difference between the not-for-profit and the for-profit world. What is the total amount of profit that health insurance companies gather each year? Significant or insignificant?
I think it varies by market. They're actually doing very well in Medicare Advantage, and they're doing well in some of the managed Medicaid contracts. They're losing a lot of money in the individual market. I'm sure you've heard them bellyaching about that. And I think the group coverage is kind of in the middle. They're becoming more and more like utilities, really, because it's a regulated business. But the question is, if you put that whole thing into the public sector, could you deliver a better product for less? I don't know the answer, but I think it's an interesting question.
There might be a potential answer in your numbers earlier there. If you saw what the Medicaid cost was, and I'm talking Medicaid, it exceeded the private marketplace, yet it insured less than 1/3 of those people. So, and when you look at those health insurers, consider that about half of them are non-profit. Kaiser Permanente, a lot of the Blues. Now they still make their own profit, but they're oftentimes vilified. And what we found is that the fundamental failure of ACA is that it never addressed the provider payment schedules like Medicare does. In fact, we found from the geriatric doctor that was here that it's too low. It's brutal on a lot of PCPs and geriatric physicians. But in the absence of any regulation in the private market, we find the numbers that you said, that there are procedures that are 5, 6 times, 100% times the same cost, and it's out of control, and it's trillions of dollars, because there's no check and balance on the private market. So unless that's addressed somehow, and every major industrialized nation that has more favorable outcome as far as coverage, Japan, Canada, England, Switzerland, Italy, not all nationalized healthcare have regulated provider payments. There's a number of physicians in here, and be fascinating to get your take, but it's almost un-American to go to a single payer system because there's so much freedom in a provider saying whatever they want.
But that is a good in-between that people talk about sometimes, and you raised it as well. I know, going towards a system where we regulate what we pay providers, but we still don't have the single payer. And now we're out of time. So, thank you very much. Thank you very much.